Good evening, everyone, and thank you for joining us tonight. My name is Karen Brownlee, and I am the Adult Program Coordinator at the North Suburban YMCA in Northbrook, Illinois. In that role, I bring a variety of programs to adults in our community, including social networking opportunities, donation drives, brain games, and the Adult Education Series, which you are attending tonight. It is my pleasure to welcome you to Illinois Bone and Joint Institute's 11th Virtual Adult Education Series program with the North Suburban YMCA. Since April, the amazing staff at IBJI has collaborated with the Y to bring virtual education programs to our community, covering topics from how to handle injuries during COVID-19 to concussion management to pet therapy, and together we've been able to bring valuable information to more than 1,300 people over the past 10 months. Tonight's program, entitled Neck, Back, and Spine Pain, will be hosted by Dr. Mikhael, and he will explain common conditions affecting your neck, back, and spine, along with options available to treat them and varied ways to help alleviate pain and disability. Dr. Mikhael is an orthopedic surgeon specializing in surgical treatment of spine disorders such as disc herniations, stenosis, fractures, instability, and degeneration. His special interest is in complex cervical spine surgery. Whenever possible, however, he offers minimally invasive surgical techniques which help avoid complications and reduce patient recovery times. He also has extensive experience in nerve decompression surgery and complex spinal reconstruction. Dr. Mikhael works with each patient to explore conservative treatment options before pursuing surgery. His philosophy of care is to look at each of his patients from a global perspective to best understand their issues, their condition, and ultimately how they can be treated most effectively. Dr. Mikhael's efforts to improve care for patients involve his work developing new medical technologies, including a cervical fixation device and a product to stimulate bone growth. He is also actively involved in multiple research projects targeted at improving spine care. In addition to his work in the medical field, Dr. Mikhael plays guitar and sings in the heavy metal band Sincerely Sarlacc with IBJI colleague Dr. Kristen Chong and other local musicians. Sincerely Sarlacc will resume playing at Chicagoland bars and venues when COVID restrictions lift. So looking ahead, you might have more opportunities to see him perform. In the meantime, we are extremely pleased that he is here with us tonight to share his expertise regarding neck, back, and spine pain. Thank you again for joining us this evening, and thank you, Dr. Mikhael, for taking the time to offer us your neck, back, and spine pain program tonight. And please take it from here.
Oh, thank you, Karen. I really appreciate it. Thank you for inviting me.
My pleasure. We're very pleased to have you.
All right. Are you seeing my screen now?
Yes, we are.
All right. Well, again, thank you, Karen, for inviting me. I appreciate it, and I'm happy to be here. My name is Mark Mikhael. I'm a spine surgeon with the Illinois Bone and Joint Institute. Just a little bit about me. I grew up in Northbrook. I was born at Evanston Hospital, the very hospital that I do a lot of my surgeries out of, and I went to Glenbrook North. And in fact, I've spent a lot of time at the North Suburban YMCA, played basketball on those courts, worked out in those gyms. So I've been around this area for my whole life. I did my residency at the Mayo Clinic in Rochester, Minnesota. Great place to train. And they really instill on you their philosophy that the needs of the patient come first. So every decision we make is made for the needs of the patient in front of anything else. I did my spine surgery fellowship at the UCLA Comprehensive Spine Center. And the building that you see here is the Spine and Orthopedic Hospital. It's a hospital that's built only for spine and orthopedic surgery. So all of the anesthesiologists, the nurses, the therapists, they all cater to just spine care. It was a very unique place to be and a very unique place to learn. In terms of practice, I'm a surgeon. I do all kinds of surgery throughout the spine, from skull to pelvis. I do small, minimally invasive percutaneous procedures. I also do very large front-back spinal reconstructions when necessary. So just a little bit of a plug for Illinois Bone and Joint Institute. If you're not aware, we do have this Back to Life walk-in clinic, and it's meant for kind of an urgent care for neck and back pain to avoid going to an ER or a general medicine walk-in clinic. So let's talk about, let's go over what we're going to talk about today. And it looks like we've got over 500 participants, which is great. Thank you for joining us. I'm going to actually focus mostly on just defining what the most common spine conditions are, because we've heard of disc herniations in the past, we've heard of stenosis, we've heard of degenerative disc disease, compression fractures. These are very common terms and very common conditions that maybe people have heard, but they don't really have a grasp as to what these things are. So I will outline exactly what these things are and explain it to you. I'm going to actually focus mostly on non-operative management. The reason for that is, as a surgeon, obviously I do enjoy doing surgery, but I actually only end up operating in about 10% of the patients I see, meaning that 90% of patients that come into the office with a spine problem do get better with non-operative management. So it is actually the bulk of treatment. I'll only touch on the surgical stuff because that stuff can be individualized and tailored to when you reach that point. So the spine is broken up into just three main regions, the cervical, thoracic, and lumbar area. The cervical area is the neck area, thoracic is the mid-back, and the lumbar is the low back. I wrote on the bottom here, you have to understand where in the spine you have a spinal cord and where you have a cauda equina. And I'll explain what I mean by that. But the spinal cord comes from the base of the brain, travels down the spine, and the spinal cord stops at about L1 level, right where my pointer is. After that, it becomes what we call the cauda equina and the horse's tail. What that means is this is a view from the back. You can see the spinal cord stops here at about L1, and after that, it becomes a bunch of dangling nerve roots kind of hanging down. And they call it the cauda equina because it resembles a horse's tail. I was going to put a picture of a horse's tail right next to this, but then I realized I'm going to show you the back of a horse, and I didn't think that that was probably the best idea. But the reason I specify these zones is cord level versus cauda equina level have very different implications when you're talking about some of these pathologies, and I'll get to that as we move forward. So where is the problem? I tell friends and family all the time, I don't actually treat neck pain or back pain. I usually treat either arm pain or leg pain. Reason being is when you have a problem in your neck, people don't typically complain to me about their neck. They complain to me about their shoulder, arm, forearm, hand. And when they have a problem in their low back, they complain about pain in the buttocks, thighs, legs, or even the feet. And that's where you say, where's the problem? It's coming from your spine, even though you're feeling it in your arm or your leg. The reason for this is the nerves that come out of the spine form the sciatic nerve. So everybody's heard of sciatica, but sciatica is actually a generic term for individual nerve roots that actually join together. All of these nerve roots together form the sciatic nerve, but individually we call it a radiculopathy, and we name that radiculopathy based on the nerve root. An L1 radiculopathy, an L5 radiculopathy, all together make a sciatica. So let's dive right into common spine conditions. Every single one of you, I'm sure, have heard of a herniated disc or a bulging disc or a disc protrusion. All of those terms are the same are different terms for the same condition. And what that is the discs are the shock absorbers between the bones. So on this drawing here, the bones are these yellow kind of cube-like things, and the discs are the blue cushioning between them. If you take one of these discs out, you look at it like this. It's actually made out of two different materials. The outer material is very firm and fibrous, and the inside is kind of gelatinous. And so I have this picture of a jelly donut, and this is exactly what you consider a disc. The outside is very firm and has substance to it, and the inside is made out of jelly. Now, what a disc herniation is you get a hole or a puncture in the outer capsule. Just like in this jelly donut, you see this is where they filled it. You consider this a hole in your lumbar disc. And when that jelly squirts out of there, that's what a disc herniation is. So here's a diagram of it. Here's the outer disc. Here's that inside jelly, and you can see the jelly has squirted out. And when the jelly squirts out and it bangs up against one of those nerve roots, guess what? you get a lumbar radiculopathy, an electric pain down the leg. That's what a disc herniation is. The same thing can happen in the neck. So here's another diagram where here's the outer capsule, the jelly is squirted out, it's banging up on a nerve root in the neck. And just like in the low back, you can get a cervical radiculopathy or an electric feeling down the arm from one of these pinch nerves from that jelly squeezing the nerve root as it exits the spine. Now, this slide here is the key to treatment. When the disc goes and bangs up against the nerve becomes inflamed. So I kind of have a drawing here where if this is a normal nerve root, this is what an inflamed nerve root looks like. And what I want to show you is when nerves get inflamed, they actually swell. So they increase in size. And when it swells in a situation where you either have a herniated disc or something else pinching it, that's where you get the pain. It's not actually from the herniation touching it, it's from that inflammation causing the nerve swelling. And that managing that swelling is the key to the non-surgical treatments, and we'll get to that as we move on. So let's move to the next condition, stenosis. Again, everybody's heard of stenosis. Some people don't have a grasp, but I actually saw a patient today. She came in, I said, "Hi, so where's your pain?" She goes, "I got stenosis." I said, okay. Well, why don't you tell me a little bit more about that? Stenosis, in general, the term stenosis just means narrowing. So in the spine, obviously we call it spinal stenosis, meaning narrowing in the spine. You've heard of, cardiac stenosis, narrowing of the vessels in the heart, vascular stenosis, narrowing of the vessels in the legs. But spinal stenosis, we talk about the spine. And this manifests itself in different ways. So I just said a disc herniation in the neck is electricity on the arm. A disc herniation in the back is electricity on the leg, which is very similar. Stenosis between the neck and the low back are different. In the lower back, it causes pressure on the cauda equina, or the horse's tail, like we talked about. And the symptoms you get still go down the leg, but instead of electricity, it's a very heavy, aching, fatigue feeling. Patients will come in and they'll say to me, "Mark, I can't walk very far. I can only walk about 10 feet or stand for about a minute, and then I have to sit down. But when I sit down and lean forward, my symptoms are gone." That's someone telling me in their own words, "I've got lumbar spinal stenosis." And then I have this thing called the shopping cart sign. So next time you go to Jewel, you look around, you see all these people bending over their shopping cart to finish their shopping. Those are all the people with spinal stenosis. And the reason for that is they're mimicking sitting down, which is helping alleviate some of their symptoms. So spinal stenosis in the lumbar spine, you get a heavy, toothache, fatigue feeling in the legs. The reason that spinal stenosis is not terribly serious in the low back is because of the cauda equina. Now, remember what I said earlier, the spinal cord stops when you get to the low back, and instead of it being a fully formed cord, it is just a bunch of dangling nerve roots. Those nerve roots can clump together and get very, very close to one another. And so you can narrow the spinal canal down to the size of a pinhole before those nerve roots actually get irritated. And that's what this is showing. I mean, you can have stenosis from just a generalized bulge or stenosis from a generalized arthritis and thickening of the tissues. And the nerve roots can kind of get closer and closer and closer until it's very, very tight, and then you get symptoms. And that's not a very dangerous situation in the low back. However, in the neck, that's a different story. Because in the neck, just remember, it's still a spinal cord, and the spinal cord, it doesn't take a lot of pressure to get irritated. So if you look at the neck, instead of it being a bunch of individual nerve roots, you have this big round cord, and just a little bit of stenosis will start to deform and put pressure on the spinal cord. This causes something called myelopathy. Now, myelopathy does cause arm symptoms, but not in the way that a disc herniation does. So I said the disc herniation causes electricity. When you have stenosis in the neck, you get what we call myelopathy. The earliest signs of myelopathy are tingling in the fingers, problems with fine motor skills, so problems buttoning your shirt. Patients will tell me they have difficulty handling coins, changes in their handwriting, generalized clumsiness. And then I examine their reflexes. They have very abnormal reflexes and some walking difficulties. These are signs of pressure on the spinal cord. The reason that this is more serious in the neck than it is in the low back is that myelopathy, when it gets worse, even if you treat it, it may not get better. Meaning, I always take out this piece of paper and I draw this graph for patients who have myelopathy. And this is function and this is time. And when you have pressure on your spinal cord and you start to have injury to the cord, it's not a gradual decline. What happens is you function perfectly normal for some kind of period of time, and then you take a very abrupt step down in function. And that could be as simple as, I don't know, over the course of the last week, I started to notice my hands are a little bit numb and I'm having trouble with my handwriting. And then you stay that way for some kind of period of time, and then you take another step down in function. And so it's very abrupt steps. The reason you want to address this right away is it's hard for people to recover that function back. So if I do surgery to fix the problem on this step, I tell the patient, I can't promise you I'm going to put you back up here, but I can promise you this is where you're going to stay, that you will no longer go down this stair step. So when you find someone with stenosis in the neck and pressure on the spinal cord, this is the one situation where surgery, early surgery, is typically the first line recommended treatment, because the longer you wait on something like this, the less chance you have to recover if you keep going down those steps. So this is kind of how I explain to the patient. I don't want you to go any further down. Let's just stop this here. So this is the one situation I'm talking to you about today that surgery is a must. So the next very common spine condition that I'm sure you've all heard of or all aware of is degenerative disc disease. And I pretty much tell patients, if you live long enough, everybody gets it. Or, you know, one way to say it is your chances of getting degenerative disc disease, the probability of you getting degenerative disc disease matches your age. So 85%, 90%, when you get 85, 90, everybody gets worn out discs. Now, to keep with the theme, degenerative disc disease also manifests itself as leg symptoms, but a little bit different than both herniated disc and a little bit different than stenosis. When you have degenerative disc disease, what that means is the disc, so this is a normal disc right here, this disc is becoming worn out and the space between the bones is shrinking. When that happens, the nerve, when it comes out of the spine, when this space goes down, this space goes down. So you can see here, as this collapses, you start to get pressure on the nerve. Because degenerative disc disease is a process that takes decades, so you go your whole life kind of wearing out this disc, and you reach a tipping point where it starts to bother that nerve. People don't come in complaining about electric shocks. What they complain about is a very dull toothache type pain, because you know toothaches are caused by nerves too. They say, Mark, it feels like I've got like a chronic constant toothache that goes across my buttocks and into my thighs and maybe a little bit into my calves. Not electricity, just this chronic ache. And that's more classic of degenerative disc disease. The other thing that's classic for degenerative disc disease, which is the exact opposite of stenosis. Remember when I was talking about stenosis and I said the shopping cart sign, people with stenosis want to sit down because it alleviates their symptoms. People with degenerative disc disease want to stand up because they have less intradiscal pressure. So you have more pressure on your discs in the seated position, and you have lower pressure on the disc in the standing position. So the patient with degenerative disc disease, they won't sit down in my office. They're going to stand up and pace the room, and I go, okay, well, I think I know what I'm dealing with right now. This concept of intradiscal pressure is key to treatment with physical therapy, and I'll get to that section when we get to the treatments. The last very common condition that I want to touch on this evening is compression fracture. So all of these conditions I've been speaking to you about are the ones that I see the most frequently. Obviously, I'm not talking about everything you can talk about in spine, but these are the most frequent ones. Unfortunately, compression fracture is one of those things. And what a compression fracture is the bones in your back, they crumble on themselves or collapse. And I like to explain to patients as thinking about packing a snowball. When you collect snow, initially, it's very compressible until you get it down to a very tight ball. And when you pack it down tight, it gets very firm and hard. And that's what happens with the vertebrae. When you have a compression fracture, the bone kind of implodes on itself and then compresses down until it's a very firm, packed scenario. Just kind of what you see here. This can be due to a trauma, a fall from a height, fall from a ladder, fall from a standing position, but the most common reason for this, unfortunately, is osteoporosis. And osteoporosis itself does not cause a problem in the quality of the bone, it's a problem in the quantity of the bone. And what I mean by that is if this is healthy bone, osteoporosis still has very healthy, normal bone. It's just you make less of it. And because you have less of it, you're prone to compression fractures. The treatment of compression fractures actually is the prevention. Prevention. Because if you manage your osteoporosis early, you can prevent these fractures from happening. Because one of the biggest risk factors of having these fractures is having one already. And so patients will say, I'll say, hey, have you spoken to your internist about your osteoporosis screening? Yeah, they said everything's fine. Well, if you're older than 65, you may want to start some kind of treatment, even if your DEXA scan is in the normal level, because you don't want to wait until you have the compression fracture. So how do you test for it? There's this thing called bone mineral density test, and they give you either a T-score or a Z-score or both. And what those scores are is they're an average of your bone quality compared to the population of the same age and sex. And you're either rated as very high in your population or very low in your population, and that's where you call it osteoporosis, osteopenia, or normal bone. Any medication for osteoporosis is targeted at rebuilding the bone and maintaining the quantity of that bone material. So, what if you do have a compression fracture? Well, typically, most of these are actually treated non-surgically, and they heal. I wrote 6 weeks. Actually, it's more like 12 weeks. But I take patients through the progression. So, in the first month, the fracture starts to kind of get stuck together with cartilage, and people feel about 50% better. In the second month or 8 weeks in, it becomes disorganized hard bone, and patients are about 85% better. And by 12 weeks, they're 95 to 100% better. And that's the usual scenario. I think surgical treatment for compression fractures is actually unusual. Circumstances where you'd want to do some kind of surgery for this is if it's very severe and collapsed, causing instability. If you wait a month or 6 weeks and it's just not healing or continuing to compress, you may want to consider some kind of surgical intervention. Or if it's pinching on a nerve and you have some kind of neurologic deficit, surgery is the indication. But those are the exceptions, not the rules. One thing you may have heard about is injecting some kind of acrylic cement into these. It has two names, either vertebroplasty or kyphoplasty. And how that's performed is you have a compression fracture here, and percutaneously you put a catheter in there, and you fill up a balloon with air. And this balloon creates a void. It can restore the height, although I think this cartoon's a little bit more optimistic than reality. You don't really create a lot of height, but what that balloon does is it packs the bone around it and creates a cavity. And then you take the balloon out and you fill that cavity with an acrylic cement, so you have instant hardening of the bones, so that fracture does not collapse anymore, and it's supported internally. I typically only send people for kyphoplasties or vertebroplasties if I follow them for at least a month and I do not see any evidence of healing. And like I said, that's the exception, not the rule. Most people heal with just time. Sometimes the fractures get so severe that you get a really, really bad deformity and compression of the spinal cord, and then that's when an actual surgery is necessary. And so sometimes you need to go in there and stabilize it just like this. Again, that's rare and unusual. So let's move on to non-operative management of some of those common spine conditions I talked about. And I want to bring up this slide again, where I showed you that the nerves, when they're inflamed, they swell. That's the key. You just remember that, because if you can get this inflammation to go away, the nerves will kind of shrink back up to their happy size. And why is that important? Well, let me start with physical therapy, how that can be helpful. Physical therapy is actually very beneficial for virtually every single spine condition. Really, because one, every therapist will teach you proper bending, lifting, twisting techniques, which you really should know. I mean, it's good for proper back health. But the key to physical therapy is core strengthening, homegoing exercises, and generalized back health. So if you look at this diagram, I touched on this when I was talking about degenerative disc disease. And you remember I said in degenerative disc disease, when you're sitting, you have more pressure in the disc than when you're standing. So this diagram shows intradiscal pressure, pressure inside the disc. And you see that pressure in the disc is the lowest when you're laying flat on your back, and it's the highest when you're sitting in a chair, leaning forward and carrying weights. So anybody who does this with regularity, stop, because that's not a good idea. I can't imagine that anyone would do this, but don't. So how do you use that to your advantage in therapy? Core strengthening. So I have a picture of my abs here just to show you what it would look like. If you strengthen your core muscles, and that's both your abdominal muscles and your back muscles, what happens is you decrease the pressure in your abdomen, and by decreasing the pressure in your abdomen, you decrease the pressure in the disc, and that offloads the disc. And even if it's just a few pascals of pressure, having a very strong core is enough to actually offload the disc enough in most of those conditions, herniations, stenosis, degenerative disc disease, to actually give patients a significant amount of relief. So I am a strong proponent of physical therapy for virtually every spine pathology. There are a few rare exceptions. This is an idea of some of the homegoing exercises you would work with your therapist on. I took this directly from the American Academy of Orthopedic Surgeons website. And these are kind of the things that most therapists will work with you on. It's important to actually work with a therapist. You know, sometimes patients will say, can you just give me the exercises? Proper technique is actually the key. If you actually do these incorrectly, you can actually cause more harm than good. So you want a therapist to kind of at least teach you some of the things to look out for when doing these, so that you make sure that you do them right. And if you're going to do anything, you want to do it right. So back to inflammation. Medication-wise, the first line of treatment for all of these conditions is an anti-inflammatory. Why? Because if you get the inflammation off the nerve root, it shrinks back down to its happy size. So anti-inflammatories come in two varieties. There's steroids and there's non-steroids, or NSAIDs, as you probably see in the pharmacies. NSAIDs come in multiple varieties: Advil, Motrin, Aleve, Bayer, Bufferin, Indocin, Celebrex. I mean, there's a ton of them. Duexis, they get fancy because now they have combination pills and things. So I'll say to a patient, have you taken any Advil? And they're like, yeah, I took 2 on Saturday and it didn't help, so I stopped. Well, it was a nice effort, but the best way to take anti-inflammatories if you're going to treat an acute spine condition is scheduled for a fixed amount of time. So for example, 3 Advils 3 times a day for 3 weeks. Even if your symptoms get better in that time period, you want to take it scheduled. The reason being is if you take it on a fixed schedule like that for a fixed period of time, you kind of get a steady state of medicine in your bloodstream, and you really start to smother and smolder that chronic inflammation, and you give enough time for the nerve roots to kind of shrink down. as opposed to just taking 2 sporadically, you're not really giving the treatment a valiant effort. And I tell you, if you do it this way, you'll really notice a considerable difference. That being said, if you have sensitive stomachs, you want to take it with food, or you want to take it with a Prilosec or a GI protective medication. And of course, always consult with your internist whether or not you have the right kidney function for this. You have to have normal kidney function to take these NSAIDs. When you get outside of non-steroidals, well, that brings us to steroids. And steroids come in 2 varieties, the kind you take by mouth and the kind that's injected. When you take steroids by mouth, usually I would prescribe you something like a Medrol dose pack. And what that is, it's a convenient punch pack. It looks something like this, where you take prednisone over a course of 6 days in a tapering fashion. So day 1, you take 6 pills, and day 2, you take 5, and then 4, and then 3, and 2, 1. And that is a very, very strong anti-inflammatory that often can get a lot of this inflammation out around the nerve roots, and the nerve roots shrink back to their happy size, and you feel like $1,000,000. The other option is epidural steroid injection. So when you take the steroids by mouth, they go all over your body, in your bloodstream. And the nerve roots, they do get a blood supply, but they don't have a very hefty blood supply. So just a small smidgen of that medicine actually gets to where it needs to be. For many, many patients, it's worth doing because it works wonders and they're very, very happy. However, in some patients, it's just not enough to do the job. And that's where injections come in. Epidural steroid injections are injecting the cortisone exactly where you need it. And people say, oh, you mean like what my wife had when she was pregnant? No, that's epidural anesthesia. Epidural steroid injections are cortisone on the nerve root. So here you can see the needle goes in and you squirt the medicine right on the nerve root. So this is a picture of the needle going in, and they're injecting a dye to make sure that they're in the right spot. And you can see here the dye, where's my pointer? You can see here that the dye is kind of outlining the nerve root, so they know that this is in the exact right spot for where the medicine's going to go. Actually, that's pretty cool. I mean, you can see the nerve root right there. And then they inject the cortisone right in that exact same spot. So people often ask me, well, Mark, isn't that just a Band-Aid? Like, aren't I going to need surgery anyway? The answer is no. And it goes back to what I was saying about inflammation. When a disc pops out and hits the nerve root, it's not the presence of the disc that's giving most patients pain. It's the swelling of the nerve root, because the nerve root's inflamed and it's swelling and it's just too tight. If you deliver medicine right where it needs to be and the nerve root shrinks back to its normal size, oftentimes it can accommodate the presence of the disc in its space, and you have no pain, and you just go back to your normal life and your body takes care of the rest. And that's the majority of patients. So it's not a Band-Aid treatment. It's actually a treatment that does take care of the job for you. So I always encourage people to try at least one shot. I say a bad pun, I say it's worth a shot. But you know, you don't want to skip straight to surgery without trying it, because I think most people will be pleasantly surprised at how effective this can be. So if you failed therapy and you failed medications and you failed shots and you're still very, very unhappy, that's where surgery comes into play. And you can see that makes me happy and smile. But joking aside, surgery is only necessary when you have exhausted all conservative measures, and those are the ones that I talked about. Now, the results from surgery are excellent with proper patient selection. What do I mean by that? Every patient will come and say, I have an uncle who had back surgery and he's terrible, and my neighbor said never have him operated. I can't speak to your uncle or your neighbor or whomever, but I'll tell you that if you come for surgery and we've identified the problem and the surgery takes care of that exact problem, the results of spine surgery are typically excellent. I think that the exceptions are those ones that you're hearing about. because you're not seeing a lot of the patients every day on the daily basis, and you're not seeing them in follow-up. So the key to this is you have to treat the patient, not the images. You don't treat the stenosis, you treat the actual symptoms that they're having. And so surgery, again, I don't want to go into this too much because I could actually talk for a decade straight about different surgical techniques, but they come in different varieties. There's micro decompressions, micro discectomies, laminectomies, fusions, instrumentation, screws, O-lift, T-lift, A-lift, all these things. It doesn't matter. As long as the procedure is tailored to what your symptoms are, your outcomes will be good. And that's the real key. Making sure that you tried everything you can, and then if you're going to fix it, you fix the problem at hand. And these are just different tools as to how do you accomplish that. So one great resource for all of you, if you have questions about spine conditions or spine surgeries or just generalized spine management, if you go to the IBJI website and you click on the services tab, you'll find under services, go to spine. And if you just kind of just navigate through a little bit, you'll find this area that says conditions and treatments. And here under this main menu section, you see non-surgical care management, surgical care management, spine conditions. If you click spine conditions, there's videos that show you what I just showed you. What's stenosis, what are disc herniations, what's sciatica. If you do spine surgical care and management, you'll see videos and clips of different types of surgeries, cervical fusion, lumbar fusion, microdiscectomy, laminectomy, all these different treatment options. And then the non-surgical care kind of talks about epidural injections and some of the stuff that I already talked about. So this is a great resource for you. Another great resource is a website called understandspinesurgery.com. And if you search for a spine surgeon in your area, you might see a guy like that. And a very similar tab right here, spine procedures and conditions. If you click that, you'll get the actual same images that I showed you. That's where I got all of these, is from this website. And it's also a nice resource for you to understand both procedures and conditions and diseases. And then the last great resource is the American Academy of Orthopedic Surgeons website, AAOS. If you go to the AAOS website, you'll see a skeleton like this, and you can pick on whatever body part you want. Really, the only important ones are the back and the neck. And if you click on those, it'll kind of take you through it. I recommend these sites because Google, you don't know the validity of whatever people are blogging about. You don't know the validity of some of the treatments that people talk about without any research or anything to back it. But if you go to these websites, our website, Understand Spine Surgery, AAOS, these are based on very clear treatment paths with a lot of history, a lot of research, and are very good, trustworthy websites. So with it, that's all I've got for you today. This is a picture of my band. This is me and Dr. Shang playing together. We were at the Cubby Bear. Unfortunately, because of COVID, we're not playing. We do have a show set in September. It's a Battle of the Bands fundraiser, and hopefully everything will be back to normal by then. So thank you for your time, and I hope you learned a thing or two today.
I think people definitely did. Thank you very, very much, Dr. Michael. There are a few questions that people sent to us that I thought I would ask you. And one question that several people put out there was, will this be recorded and can I access it later? And the answer is yes, it was recorded, and you can access it on the IBJI website as well as on the North Suburban YMCA's website. So we'll give you a couple different places that you can find it. So for those of you who are wondering where you can find this later, you can go ahead and find it at one of those two places. Some other people were asking about like looking at the slides again, and can I get a copy of that slide? Go to the website, watch the webinar, take a picture of the slide, and you'll have it. But remember, proper form is important with those exercises. So make sure if you want to learn how to do those exercises properly, definitely see a physical therapist to do that. So I'll answer those questions. And then I'm going to hit you with some, Dr. Michael. Someone asked, can the progression of scoliosis be slowed with physical therapy, a brace, or surgery?
So that's a little bit of a loaded question because there's lots of factors as to why scoliosis progresses. Age is a factor. I don't, if it's past skeletal maturity, it doesn't progress as much as it would if you're under 18. There's no role for bracing in adults because you don't have that accelerated growth, so you're not really going to see accelerated progression. So bracing is reserved for people who are not skeletally mature. That being said, in adults with scoliosis, physical therapy is actually the main treatment for adult scoliosis because of what I was talking about in those slides. Maintaining strong core and proper bending mechanics prevent problems associated with adult scoliosis. The good news about skeletal maturity is that once you reach adulthood, you don't really progress at that point.
Good to know. Awesome, thank you. Another question is, someone asked, with an epidural steroid injection, does the patient need to be in pain at the time of the injection? Do they need to be feeling their pain when they're going in for that injection?
That's a good question. I guess the short answer is yeah. Epidural injections work best at the time that you are in pain. They're not really a good maintenance type thing. I keep plugging therapy, but if you have moments where you're pain-free, physical therapy is a way to prevent recurrences. But I usually tell patients not to get, so if you're talking about a series of injections, so you had one or two and you're not sure if you should get that third one, I would say no, don't get it until your pain starts to return. And I say that for two reasons. One is, if you wait for your pain to return, it may never come back, and then you realize, wait a minute, I'm better. But also, it really doesn't. You kind of waste the injection because the reason you're pain-free is because it has alleviated that inflammation. So I guess I would say yes. Don't get it unless you're in pain. I would avoid it if you're pain-free.
That makes a lot of sense. Thank you. Someone else asked, and I don't know if this is really something that you would address or send them to someone else for, but if someone's neck is bothering them and they're in pain, would you recommend hot or cold therapy for that?
That actually is a very common question, and there's just a very generalized orthopedic answer for that. Cold therapy is best in the acute setting. So in the first 24 to 48 hours of symptoms, whether it be a neck problem, a back problem, a sprained ankle, whatever, you want to ice it or do cold therapy for the first 24 to 48 hours. Beyond that, we switch to heat.
Gotcha. Great, thank you. And for your spine, what is the best way to sleep?
So my answer to this question is the same answer for what's the best pillow, what's the best mattress, what's the best chair. The answer is whatever pillow, mattress, position gets you a good night's sleep is the right answer. And the reason being is everybody's different. Everybody's mechanics are different. Everybody's habits are different. I swear if I knew the one pillow or the one mattress that did the job, I would sell it. But I don't. And that's because everybody's so different. So the position that you're in, it actually doesn't make much of a difference based on spinal pathology. So I always tell every patient, whatever position, mattress, pillow gets you the best night's sleep, that's all that I really care about, is that you're sleeping.
That makes complete sense. Excellent. Do you also help people manage their soft tissue problems?
That's a good question. I personally don't. Not that I don't like to see those patients. I'm just not that great at it. But we do have, IBJI does. We do have great physicians within IBJI that do treat the soft tissue stuff. Specifically, we have physical medicine rehabilitation doctors and the same pain management physicians that do the epidurals. They treat the soft tissue issues. Not just with shots and pills. It's still kind of the same staple of treatment. They can do things like manual treatments, medications, therapies, and of course shots and other medications too. So I don't,
Great.
IBJI does.
Very nice. Great. Thank you. Thank you. People are asking about chiropractic, which obviously isn't what you do. Do you have any general thoughts on that for people? I hate to bring it up, but there are a number of questions, and I thought, well, I guess I would like to get your opinion.
Yeah, I don't have any issue with chiropractors. I think that they can be very, very helpful. Yeah, in fact, I have several that I actually refer to quite frequently. The one concern I have is that there's no real quality control amongst chiropractors. So they all do kind of different stuff, and unless you get to know them, you don't know which ones are really doing nice stuff and which ones are kind of being aggressive. So as long as you are with someone you're comfortable with, or someone that your doctor's comfortable with, I think they do good work. I would not recommend any aggressive manipulation of the neck because of the condition I talked about, that myelopathy condition, which I said is a surgical problem. If you're not trained to look for that problem, it's easy to miss it. And if you're seeing someone who's kind of doing these manipulations and doesn't pick up on it, that can potentially be a dangerous situation. So I always tell patients kind of a blanket statement, I wouldn't do any aggressive manipulations of your neck unless someone has already looked at it and said that you're not one of those scenarios where you have a myelopathic neck.
Got it. Got it. That makes a lot of sense, and thank you. Another question, are you taking new patients?
Yeah, I am.
Okay,
Yes.
great, great. And let's see, someone asks, to what age do you recommend surgery? I'm guessing that means, is there an age beyond which you wouldn't recommend surgery for people?
So
I have a guess at your answer, but I'll let you do it.
well, to be honest with you, it's more physiologic age than chronologic age. And what I mean by that is not all 90-year-olds are the same. And, I've operated up to 100-year-olds. But physiologically, you wouldn't even tell that they were even in their 70s. So
Yeah.
the number is not what's important. It's the other medical issues. I mean, if someone is in their 80s or 90s and have liver disease and kidney dysfunction and this and that, they're not good surgical candidates. But there are also a lot of people out there that are extremely healthy and very vibrant, and I wouldn't turn them away just because of their age. But I'd be very careful to review their medical history and make sure that they're at least fit for some kind of procedure.
That makes a lot of sense. Thank you. Someone asked if you recommend sitting on a fitness ball when you're working on your computer.
Oh, yeah, that's a good question. This is kind of in line with also people asking me about standing desks and sitting desks and the balls. They all are kind of the same type of question. Too much of anything is bad. That's really the short answer. You want back support, but you don't want to sit down all the time. Standing is fine, but you don't want to stand all day long either. One of my mentors used to say, humans are like sharks. And what he meant by that is sharks have to move to live. They can't stay still in the water. And he said humans are the same way. If you really want to live a long, healthy life, you have to move and move about. So the ball is fine, but at some point you're going to want to stand up and walk around. At some point you're going to want to have a back support. So it's really the variety that's important. I don't think one is better than the other verbatim.
That's excellent. That makes a lot of sense. Another question is, for someone with osteoporosis, do you recommend that they do weight training exercises?
Yes. Well, first of all, osteoporosis is something that, like I talked about in my talk, needs early management.
Yep.
Either by your internist. Some internists are very good at managing it and want to manage it, and that's great. Some of them, they're not that comfortable or have no interest in it, and that's when you want to see a rheumatologist. And if that's something of interest, IBJI has rheumatologists for this too, because we focus on all bone care, and we can help you find a rheumatologist to help you. But yes, weight-bearing exercises are important. because the astronauts, when they go into space and they're weightless, they actually come back to Earth with osteoporosis and osteopenia because your body needs weight on it to remodel. So weight-bearing exercises are important to an extent. Obviously, you want to, I always recommend the patients who ask me this question to do a low amount of weight with high reps as opposed to doing something very heavy.
Great, and that makes complete sense.
It should be guided by your rheumatologist or your internist.
Perfect. I'm getting a few, they're coming in like crazy now, so I'm looking at a few more to see if I can find some that are a little more generic.
Sure.
Let's see. Oh, do you take Medicare?
I do, yes.
That's what I figured, but I figured I would let you answer that. Let's see. Someone else says, okay, what if there's no sleep position that makes you comfortable? You mentioned the most comfortable bed, the most comfortable pillow, etc.
Yeah, so that's a very specific question, and I don't even know if they're referring to their neck or their back or what, but there's got to be a reason for that. So that's someone I think I'd like to take a look at their back and see what's really bothering them.
Great. Okay, and I think we'll let's see. Someone says, how do you move with a desk job? You just have to get up and move around. Someone wants to remind people of the name of your band.
Oh, we're called Sincerely Sarlacc. It's the Sarlacc pit from Star Wars, that like sand monster that comes out of the sand and eats people. Because we rock so hard, you'll get devoured.
Very good. All right, and to me, it looks like all the rest of the questions are much more specific. Dr. Michael's information is on the screen for you right here. He is still taking new patients. He does take Medicare. There are other IBJI doctors if you have soft tissue issues or if you have osteoporosis and need to speak with a rheumatologist. He's part of a wonderful team. Dr. Michael, your presentation today was fabulous. Lots of great information. Thank you all for your questions. And thank you for your answers, Dr. Michael. Clearly, you put a lot of time and effort into this. We can tell that you know what you're doing. Everyone who joined us tonight, thank you so much for your time. And again, his information's right in front of you. Feel free to reach out to him. Dr. Michael, thank you so much. Hope you have a terrific evening.
Thank you so much for having me, Karen. I appreciate it. And you have a nice evening as well. And thank you all for joining us.
Take care. Thank you. Bye-bye.